Good afternoon. Welcome to the Monday, April the 25th, 2016 meeting of the Assembly Budget Subcommittee Number 1 on Health and Human Services. I am not Chairman Thurman, David Chu, but I want to welcome you all to this hearing. I know we have a lot of items that we want to start moving through, and Mr. Thurman is presenting in a different committee. Right up at the bat, I understand that we have a colleague here who has a couple of items that she was going to present at issues 18 and 21. And with the indulgence of the committee, I think I'd like to take those items out of order so that we can let her get back to her schedule. So I'd like to bring up our Assemblywoman who chairs our Aging Committee. And I suspect you probably have others who are on the panel with you to present with you? Okay. Okay. So we will first jump out of order to issue number 18, a proposal on the Arrowhead Regional Medical Center Special Medical Response Team. And if I could ask other members of the panel to please join us, that would be great. Assembly member.
Thank you, Mr. Chu. Members, Chair. I'd like to request funding for a special medical response team at the Arrowhead Regional Center in the city of Colton. Arrowhead Regional Center was instrumental in providing care to the victims of the terror attack that occurred in the city of San Bernardino on December the 2nd, 2016. One proposal that has emerged after Arrowhead assessed its field response to the attack was a special medical response team, SMRT, comprised of emergency physicians, registered nurses, and other medical personnel who will work in trauma centers and have the skill sets necessary to rapidly respond to regional traumas. The proposal would provide training on a regular basis to those who volunteer to be a part of the SMRT team, with members of local emergency management staff, law enforcement, and state and federal agencies as necessary on how to work safely in a tactical environment during terror attacks and other life-threatening situations. The Special Medical Response Team is a unique proposal that has emerged as a result of a horrific attack on my community. But with the funding support from the state, it could serve as a model for others for other regions throughout California. Therefore, I ask that $500,000 be provided to Arrowhead Regional Medical Center in 2016-17 to help fund their efforts to create a special medical response team and make it a model that can be used in the regions throughout California. This funding would be used for additional training for the response team and portable equipment that would allow them to treat patients in the field. The ultimate goal of this program is to increase the survivability of victims and ensure that they receive life-saving trauma treatment within minutes of a terror attack or a mass casualty event. Again, I thank you, Mr. Chair, and members of the subcommittee for allowing me to present today. And I respectfully ask that you highly consider this particular budget request as we move forward.
Thank you. I know we have a number of other presenters. I just have one question to either my colleague or others. Obviously, given the most recent tragedy, we want to think about how we prevent something like that in the future. This pilot program, I think, obviously we need to do something, and certainly where the tragedy happened makes sense, but I want to just make sure whatever we do is an investment in the state and sets up a good model for us to think about because something like this could happen anywhere in California. So if others have a thought on that, would love some perspective. But why don't we move to Dr. Backer?
Thank you, Assemblyman Chu. My name is Dr. Howard Backer. I'm the Director of the Emergency Medical Services Authority, and we were asked to comment on this member proposal. The proposal is similar to several programs that our department currently manages. EMSA has two California Medical Assistance Teams, or CalMATs, that we organize, train, and outfit with supplies. And these teams can be deployed within 8 hours in teams from 5 to 50 medical personnel of all types. We also have 3 specialized CalMat teams that are organized and supported by medical systems within California, including Stanford, Scripps, and Tenet Healthcare. In addition, we coordinate and help train locally based Medical Reserve Corps teams that are comprised of medical and public health professionals and other community members whose mission is to strengthen public health, improve emergency response capabilities, and build resiliency within their own communities. Each MRC unit is also capable of responding to disasters or other medical needs anywhere in the state. EMSA also runs the Disaster Health Volunteer Database that can notify and activate all the above teams, as well as more than 21,000 health volunteers, including physicians and nurses to therapists, with details of their professional skills and license in response to any type of emergency. And finally, EMSA, the Emergency Medical Services Authority, originally developed the Hospital Incident Command System, so-called HICS, that is now a national and international standard for organizing hospital responses to effectively respond to emergencies and disasters of all types. I'm open to any questions you may have.
So again, given, I guess, the context of this ask, given the programs that are out there, do you think this is something that makes sense?
I think that we have similar capabilities and organized teams, and we may want to have a discussion with the medical center to see if they want to participate in any of these other teams. The legislature and administration was kind enough last year, or had the foresight last year, to help in fact, add some resources to our California medical assistance teams. So we have one in the north and one in Southern California at this time that are maintained and organized.
Okay, thank you. Others? Not sure, Mr. Smiley, if you have anything you want to add to that.
My name is Dan Smiley. I'm the Chief Deputy Director for the Emergency Medical Services Authority. Just to add to what Dr. Backer previously mentioned, clearly the integration of existing resources, such as what Dr. Backer mentioned, is absolutely critical. In addition, we are actively working with the State Tactical Emergency Medical Services Advisory Committee, which was formed as part of AB 1598 several years ago by Assemblymember Rodriguez. And we're actively working with both fire resources, law enforcement organizations to ensure that standardized training for these sort of terrorist events or other multi-casualty incidents are integrated into the existing system, including that of the CalMATS Medical Reserve Corps and any local fire and EMS responses.
Thank you. Department of Finance? And Elio? Okay. Anything else you want to add to that?
Yes, I would. Dr. Michael Nicky, who is the doctor who's doing this work, is trained, not just trained in medical, but he's trained in tactical. He goes with the SWAT team when they go out. He is able to do the things that, if it was 8 hours after the horrible, horrific thing in San Bernardino, by that time, if we had to wait that long, then there would have been many more casualties. So I think that this is a little different, and I think that I would like for you to come to Colton, find out what they're doing, and I'm sure you're doing a great job, but this particular model that has been developed by Dr. Nicky and maybe another doctor down in Palm Desert, I think, it's not anywhere else in California. And I believe that we need it because of the kind of resources that they brought to the table and how he could go in. People did not die because he was able to get there in time. So I believe that we really need to look very closely at the proposal. Dr. Nicky is paying his own money. Whenever he gets trained by the FBI or if he's being trained by Homeland Security, he pays his own money, his own, to train with them. And he has the highest clearances. So this is a little different than just your regular emergency response team. This is very, very high level. And I think that what happened in San Bernardino hasn't happened anywhere else in the nation. 9/11 was the last time something like this happened. So I believe that we really need to look closely at this particular proposal. And $500,000 is just not that much money for us to get it started so that it will be in other regions as well as ours.
Thank you. Obviously, at this time, we're not going to take any action. This will be pending budget discussions, but hopefully before we make any decisions, the conversations can happen so we have a little bit more consensus on what we do moving forward.
Right.
Let me ask if there's any public comment. Okay, seeing none, I want to thank the panel for this part of the discussion and move to Ms. Brown's second issue, which is issue 21 under the Department of Health Care Services, a member proposal around caregiver resource centers funding.
Thank you so much. Mr. Chair, thank you again for allowing me to speak on this item. This is the second item that I'm asking you to consider is caregiver resource centers. As chair of the Assembly Committee on Aging and Long-Term Care and a lifetime caregiver, I'm here to advocate for funding for the caregiver resource centers. Caregiver resource centers are the leading agency in California that exclusively serve and support unpaid family caregivers. Again, I say unpaid family caregivers. California family caregivers serve a critical role in our state's health care and social service system by reducing hospital readmissions and keeping seniors who often have debilitating conditions in their home and community. The economic value of unpaid family caregiving contributions in California is approximately $57 billion. This multi-billion-dollar figure represents the potential increased costs that our state would incur if the approximate 6 million caregivers in California were to stop providing support to their loved ones. Unfortunately, in 2009, during the economic downturn, funding caregiver resource was cut by 74%, one of the largest funding cuts in any health and human services program. The total allocation has gone from $10.5 million to the current funding of $4.6 million to serve 6 million family caregivers in California. You know, more than 1,000 people a day are turning 65 in California. Our senior population is growing. Our state support for the services that help them and their unpaid family caregivers must grow with them. And therefore, I ask that this committee restore the funding to California's caregiver resource centers to the tune of $10.5 million in order to get the services back to pre-recession levels. Thank you.
Thank you. Let's turn it over to DHCS. Ms. Cantwell, do you have a perspective on this?
No comments unless you have particular questions for me.
Okay. Do you have? No. LAO? Okay. Thank you for your presentation. We will certainly be considering this as part of the budget process.
Yes. Please think about our seniors.
And let me ask, is there any public comment on this item? Please step up.
Michelle Nevins, Vice President of the California Association of Caregiver Resource Centers. We were one of the sites in Northern California affected by this, and we are struggling to keep up with the demand of the caregiving situations out there. Since our cut, we are seeing record numbers, an increase from last year of 43% already. So trying to meet the demand with limited resources is extremely difficult. In addition, most of our caregivers are caring for more than one person. It's becoming pretty commonplace. So we would really just implore you to just really consider this restoration of funding. Thank you.
Next speaker.
Hi, I'm Nina Weiler Harwell. with AARP California. Assemblymember Brown already mentioned some of the research that AARP has done. We estimate there's over 4.4 million family caregivers in California providing unpaid family care to their loved ones, estimated at an economic value of $57 billion. We hear from our members all the time. They cannot qualify for other public programs. They don't know where to go for help. I can tell you personally, the Caregiver Resource Centers is where I send not just our members, my friends, when their loved ones have had a stroke or have dementia and there are no other programs they can go to. This is an absolutely vital, vital program for our millions of unpaid family caregivers, and I urge you to consider this request strongly. Thank you.
Thank you very much. See no other public comment. Thank you for presenting this. We'll obviously consider it as part of the budget process.
Thank you, Mr. Chair.
All right. When we go back to the top of the agenda for the Office of Statewide Health Planning and Development, we'll take up issue number 1. If I could ask the panel to please step up. And let's hear first from Mr. David.
Thank you, Mr. Chair and members. I'm Robert David, the Director of the Office of Statewide Health Planning and Development. I've been asked to give a brief overview, and I will do so now. The Office of Statewide Health Planning and Development, also known as OSHPED or OSHPOD, advances Californians' access to safe, quality health care environments by focusing in 3 primary areas: healthcare workforce development, healthcare data collection and reporting, and healthcare construction and financing. In the workforce area, we have 2 areas of the department focusing on healthcare workforce development: our Workforce Development Division and the Health Professions Education Foundation. Our workforce programs seek to increase access to health care for underserved communities and populations by incentivizing a diverse and culturally and linguistically competent healthcare workforce. We do this by focusing on recruiting and retaining various health professionals in areas of unmet need within our state. We increase the geographic distribution of California's health workforce. We explore new service delivery models. And since 2011, OSHPED has provided more than 6,500 awards totaling more than $189 million to support the education of health professionals in a variety of practices. One of our primary healthcare workforce development programs is the Song Brown program. Song Brown provides grants to educational institutions to incentivize increased access to healthcare providers in underserved areas through recruitment of underrepresented minorities, through clinical training in areas of unmet need, and through graduate placement as well in areas of unmet need within our state. We have a robust healthcare data collection and reporting area that serves as a healthcare collection and reporting hub, and we collect healthcare data from nearly 6,000 health facilities licensed by the Department of Public Health. This data includes hospital patient records as well as public aggregate utilization and financial data. We make much of our data available to the public, researchers, policymakers, the media, and others. We also produce measures, analyses, and reports on healthcare quality and outcomes and other related health topics. Since 2011, OSHPED has released more than 500 reports about California healthcare quality, cost, utilization, and outcomes on topics that included hospital inpatient mortality, access to community-based primary care, and first-time reports about ischemic stroke outcomes and hospital readmissions. OSHPED also coordinates and administers the California Health and Human Services Open Data Portal. More than 160 data sets have been published in open format from all 12 CHHS departments since the Open Data Initiative was launched in the fall of 2014. Mr. Chair and members, we're also the building department for California's hospitals and skilled nursing facilities. This is our largest division and our most visible program. We administer the Hospital Seismic Safety Program that focuses on strengthening California's hospital buildings so they can remain operational in the event of an earthquake or other disaster. In 2001, 40% of California's hospital building inventory, over 1,000 buildings, was classified as being potentially at risk for collapse in a major earthquake. Today, I'm happy to report that more than 91% of acute care hospital buildings in the state now comply with the Seismic Safety Act. Based upon information and schedules provided by the hospitals to OSHPD, the remaining buildings appear to be on track to meet the January 1st, 2020 deadline to withstand a major earthquake or be removed from service, and we continue to work with the remaining facilities so they stay on track. OSHPD has also promulgated a new seismic performance category called SPC 4D that will allow older hospital buildings to upgrade to a standard that will keep them seismically compliant past 2030. This is a great option, particularly for hospitals in areas of low seismicity that would otherwise have to be replaced or removed from service. Additionally, since 2011, OSHPD has reduced hospital construction plan review time on remodel and renovation projects by more than 40%. OSHPD has increased face-to-face over-the-counter services, created rapid review services for smaller projects, and we've leveraged technology to provide real-time plan review and a one-stop electronic services portal. These innovations have greatly improved our customers' experience with OSHPD and contribute to improve health and safety as well as lower cost for facility patients, staff, and visitors. And then finally, Mr. Chair, our Cal Mortgage program provides health facility construction loan insurance. California's nonprofit and public health facilities can gain access to low-cost financing for their capital construction needs through this program. Since 2011, Cal Mortgage has insured 43 loans totaling over $1.2 billion for these nonprofit and public health facilities. One recent example, and Mr. Chair, I think you'll take interest in this. Just last week, I was pleased to attend the ribbon cutting and grand opening of the new patient tower at Chinese Hospital in San Francisco. Cal Mortgage assisted in financing $65 million for that project, which is now one of the most seismically safe buildings in the city. Our budget overview of 2016-17, our proposed budget is $160.8 million and 483.6 positions. Our department is funded primarily by special funds. Many of them are fee-supported. We have a small amount of federal funding, $1.4 million in 16-17, that go to our workforce programs. And OSHPD currently has no general fund expenditures. This concludes my overview of OSHPD, Mr. Chair, and I'm happy to answer any questions. Or, if you're ready, I can turn this over to Stacy Walker to my right to provide brief updates as requested on the Song-Brown program, as well as our activities administering the Mental Health Services Act Workforce Education and Training Program. Thank you.
Thanks for the presentation. I have a couple of just brief questions. First of all, I appreciate you touching on seismic safety. That is something that many of us have been very focused on, and certainly in my city. I actually carried the legislation to do the rebuild of the Chinese hospital when I served on the Board of Supervisors. So I unfortunately was stuck here, so I couldn't attend that ribbon cutting, but I was glad that you could. You mentioned that there's still a percentage of hospitals that are not in compliance. Could you give us a sense of, are these hospitals in high-risk areas from an earthquake risk standpoint, or does it just happen to do with the randomness of the finances and the building construction timeline for these hospitals?
It's located all over the state. There are fewer than 100 buildings. I couldn't tell you the exact number of hospitals because they're obviously often hospital campuses have more than one building, but they are in different parts of the state. Obviously, we're most concerned with a few remaining that are in more seismically active areas, particularly safety net facilities. But there's been a lot of progress made, particularly, I mean, if you just look at the Bay Area, Alameda County Medical Center has just opened a new building. UCSF has opened a new building. San Francisco General. Stanford is working right now constructing one of the largest projects in California. And so there's a lot of progress being made, and we're continuing to work with the few that have work to do between now and 2020.
And then you made a reference to the 100 open data sets that you had. And one of the things that I've seen around open data is government, state government in particular, could put out hundreds, if not thousands, of data sets, and your department has chosen to put out 100. How have you decided what data to put out there?
I think And this is kind of an initial. We're going to have more data as the and other departments are going to be adding to the data sets from the Open Data Portal. I think initially it was which data sets do we get the most hits on our own website? Which do we get the most requests for data on from the media and others? I think it was kind of the top 100 list, and then we'll be adding to that as we move forward.
That's helpful to hear. What I often find is many agencies put out data sets that show the good work you're doing as opposed to data sets that show what we could probably need to focus on or want to see improvements. So I think if there is California demand for data, it's good that you guys are doing that, and I will look forward to take a look at what data sets you have. I do know we are going to have a full-blown conversation about the Song-Brown proposals, so I'll probably hold that for now, but let me just ask Department of Finance, anything? LAO, colleagues? Public comment, just on the general overview.
Kimberly Chen with the California Pan-Ethnic Health Network. I want to first express our appreciation for OSHPED's work in healthcare workforce development. We do consider ourselves in partners in making sure California's underserved communities have their needs met, especially many of those are from communities of color and low-income communities. Also want to appreciate many of the workforce reports that that OSHPED puts out. We do really rely on those and are very much looking forward to the integration of more demographic data from allied health professions. We understand that information is coming through, collected in the next round, so very much looking forward to those reports when they come out. Thank you.
Great. And unless there's any further comment, we can move to the next issue, but what I'd like to do is ask Madam Secretary to please call the roll for quorum.
Thurman, Bonta.
Here.
Chu.
Here.
Grove, Harper.
We technically have a quorum. Why don't we now go to issue number 2 for the Song-Brown Healthcare Workforce Training Program update, as well as stakeholder proposals in this area, and I would just turn it back to OSHPED.
Good afternoon, committee members. I'm Stacy Walker, and I'm the Deputy Director for the Healthcare Workforce Development Division at OSHPED. The Song-Brown program, as Bob said, provides grants to educational institutions to incentivize increased access to healthcare providers in underserved areas through recruitment of underrepresented minorities, clinical training in areas of unmet need, as well as graduate placement in those areas. In fiscal year 15-16, the program will expend approximately $14 million through 3 types of funding. First, we have capitation funding for existing residency slots. These funds are spread out over the duration of the residency. Then there is funding for special programs designed to explore innovative approaches to increasing the number of professionals practicing in areas of unmet need or improving the cultural and linguistic competency of residents. And then third, we have base funding to support overall programs. The 2014 Budget Act provided one-time funding of $4 million for Song-Brown to fund new primary care residency slots. With this money, the Song-Brown program supported the creation of 26 residency slots across 17 existing programs. These programs received $150,000 per resident for up to 3 residents, so up to a total of $450,000. The monies were spread over 3 years. As to whether these slots will continue once established, it's difficult to say. Establishing new residency slots can be both time-consuming and expensive. These funds act as a supplement to help establish the new slots. There are differences in funding models, and the site's funding model will drive whether they're in a position to continue supporting the new slots. That concludes my comments on the Song-Brown program. I'm available to answer questions.
Thank you. What I'd like to do at this point is we have a number of stakeholders who have a proposal in this area. If I could ask maybe the department to stay, but if I could ask others if you would mind just sticking around to give an opportunity for CMA and the California Primary Care Association and others to make the presentation, that would be great. And I'll turn it over to the stakeholders, however you would like to present.